Welcome to Targeted Oncology, our breast cancer virtual tumor board. Thank you for participating. Today, we're going to talk about a number of different cases that I think will be pertinent to your clinical practices and to talk about new ways of treating breast cancer. Our participants today include a number of medical oncologists as well as our pathologist. I'm joined by Avita Sadamin, who is a pathologist at the Cancer Institute of New Jersey and Rutgers University, and has a lot of experience with decision-making and testing for HER2-positive breast cancer, PD-L1. I'm also joined by three medical oncologists, my colleagues, Dr. Adam Brevsky from the University of Pittsburgh Medical Center, Dr. Ian Krop from Dana-Farber Cancer Institute, and Dr. Tiffany Traina from Memorial Sloan Kettering Cancer Center. I'm Hope Rugo from the University of California, San Francisco's Comprehensive Cancer Center. Today, as I mentioned, we're going to focus on breast cancer in this Targeted Oncology virtual tumor board. My colleagues and I will review 4 clinical cases. We'll discuss an individualized approach to treatment for each patient, and we'll review key clinical data that impacts our decision. And then the panel will discuss how these data impact our clinical practice in each setting. Thank you for joining us. Let's get started with our first case. And Dr. Ian Krop will start and talk about a case of a patient with early stage HER2-positive breast cancer.
Thanks, Hope. I think I have a case that's interesting both because it presents some good medical oncology discussion points, but also some good pathology discussion points as well. So this is a 52-year-old postmenopausal woman who presented with palpable masses in her breast and axilla on a routine annual exam. This is a otherwise healthy woman. She has 2 children, age of menopause was 49. She doesn't have any significant comorbidities and no family history of cancer. On that initial imaging to work up the palpable mass, a mammogram demonstrated a 2.7 centimeter tumor in her right breast corresponding to the palpable abnormality. And a breast MRI confirmed the tumor as well as right axillary lymph node involvement with approximately 2.5 centimeter node. So this led to a biopsy of both the breast and the node. The biopsy of the breast demonstrated poorly differentiated invasive ductal carcinoma. The cancer was strongly estrogen receptor positive in 90% of cells, progesterone receptor negative, and a relatively high Ki67 of 50%. The HER2 analysis showed the IHC was 2+ or equivocal, but the follow-up FISH demonstrated 4.5 copies of HER2 and a HER2 to CEP17 ratio of 2.2. So this was a positive FISH result. The FNA of the axillary node confirmed adenocarcinoma in the node. Based on these results, she went on to receive neoadjuvant systemic therapy with dose-dense AC followed by paclitaxel with trastuzumab and pertuzumab. With the first cycle, she did fine, but in the second cycle, she did develop grade 3 diarrhea. We instituted an aggressive antidiarrheal regimen with loperamide, and the pertuzumab was held for that cycle. Fortunately, the diarrhea then resolved, and she was able to continue with resumption of the pertuzumab and complete the remaining cycles of paclitaxel and HP. She then underwent breast-conserving surgery and an axillary dissection, and fortunately was found to have a pathologic complete response.